live to the audience. Over to you, ma'am.
Good evening to all. I am Dr. Komal Mandavkar from Medical Team JB Pharma. On behalf of JB Pharmaceuticals, welcome you all for the today's Lead HF program. It's a privilege that today we have with us all the eminent expert faculties in the field of cardiology who are going to share with us the best of ACC Congress 2024 highlights. To begin with, the agenda of today's meeting. Today's moderator, Dr. M. Srinivas Rao sir, will first do the introduction and set the context for this meeting. Then Dr. Nihar Mehta sir will do a presentation on the best of ACC Congress 2024 highlights, followed by there is an expert panel discussions and Q&A sessions with all the Indian experts. Now I will introduce our today's faculty. Our moderator, Dr. M. Srinivas Rao sir. He is a senior consultant cardiologist from Apollo Hospital, Hyderabad. Our eminent speaker, Dr. Nihar Mehta sir, a senior cardiologist from Jasnok Hospital, Mumbai. Our national expert panelist, we have Dr. Z. Hamdulle sir, a very senior consultant cardiothoracic surgeon from Masina Hospital, Mumbai. We have Dr. Devanu Ghosh Roy sir, senior consultant cardiologist in charge of cardiac cath lab, Peerless Hospitex Hospital and Research Center, Kolkata. And we have Dr. Viveka Kumar sir, a Principal Director and Chief of Cath Labs, PanMax Cardiac Sciences, Max Healthcare, Delhi. So I welcome all the esteemed faculties. Now I request our today's moderator, Dr. M. Srinivas Rao sir, to please set the context for the meeting. Sir, please.
Thank you very much, Komal, for introduction to the audience, and then also the esteemed panel, and then the Dr. Mehta, who is going to present the best of ACC 2024. And we know that recently we have the ACC 2024 has been concluded very successfully, and there are very interesting trials, both in terms of heart failure in CV diseases and also other diseases in the cardiovascular system. And they are very interesting articles. Of course, we're going to have a half an hour time, about 20 minutes time for presentation. And subsequently, we have a esteemed panel who is going to discuss out various points and dissect the trials which are being presented by Dr. Mehta. So then, as we know, some of the trials which are chosen, also those trials which are recently presented there were pertaining to heart failure, particularly with the reduced ejection fraction, and also setting up acute MI. And also one other trial Dr. Mehta is going to present is also heart failure with preserved ejection fraction, which is an offshoot of a previous trial called Paragon. And that trial is now called Paraglide trial. Is also going to something, a little analysis of this trial as well, which is presented. And also to top it all, is also going to present a little bit about inclisiran. The inclisiran trial is not a trial, but it is what is observational data that they have presented in ACC. So, over to Dr. Mehta, and I welcome all the esteemed panelists to be actively participating in this particular presentation and also subsequent discussion. Thank you so much.
Thank you so much, Dr. Rao, for the lovely introduction and laying the platform for today's discussion. Warm welcome to our panelists, and it's a pleasure to be here. Thank you, Dr. Komal, and the entire team from JB for organizing this lovely event. So basically, today the idea of having this talk today is to discuss in brief a lot of these trials which do come up. Now, when we see the summary slides and when we attend these meetings, there are a lot of trials which are released, late-breaking trials. ACC is they have some of the best, most up-to-date presentation, and the presenters are the actual trialists. They are the primary investigators. So to get the inputs from them is actually fabulous. But sometimes it gets a bit hard to understand what we should take away and what we should not. Because while we, of course, want to take positive messages from these trials, we should also understand what the statistics are telling us and what they are not telling us. And that is what I will try and cover in the next 10 or 15 minutes. and then hopefully we can have a very good discussion on some of these trials. So we've selected these trials in 3 or 4 aspects of cardiology. Heart failure being our primary goal, a little bit of lipidology, something on coronary intervention, and a few more trials which we will discuss as my slides go ahead. So some of the insights, and please note that a lot of the things I say will be things which I have taken back from these trials. So I'm going to discuss the following trials. One is on quadruple therapy in heart failure, some subsets of the Paraglide trial, the DAPA-HF trial, something about heart failure in preserved and mildly reduced ejection fraction, the inclisiran, something on the IMPACT MI trial, that is the use of empagliflozin in MI, as well as the PREVENT trial, which is on PCI. So let's start right away with the initial trial, and I thought this should be the first trial we discuss, because according to me, this is one of the most impactful trials which was released in the ACC this year. Now, we know that we have all been made to understand the quadruple therapy, the 4 pillars of heart failure with reduced ejection fraction. But we also know that very few amount of people and patients that we have of heart failure are actually on the therapy required. This trial answers a very key question, is that how soon can we start the 4 classes of drugs? Should we start them straight away, or should we start them one by one? There have been trials in the past called the Strong HF trial, which have been has sort of answered similar questions. So some of the slides I have are from previous trials so that we get a context and then we know how to interpret the current trial. So the Strong HF trial, which was released in the Lancet in 2022, showed us that when we rapidly up-titrated guideline-directed medical therapy, all the efficacy endpoints that you'll see here of 180 days all-cause death and heart failure, the heart failure admissions, and the quality of life, as well as the BNP and signs of heart failure, were all favorable to the rapid titration of guideline-directed therapy. So a close follow-up after discharge, acute heart failure hospitalization, when we rapidly up-titrate, it leads to a better quality of life, lower readmission rates, and a better all-cause mortality. Now we know this, but what this trial told us is something a little bit different and also really impactful. Now the objective of this trial was to see the degree in which newly diagnosed heart failure with reduced ejection fraction patients are eligible for this therapy, and there were 23,000 patients recruited. Out of these, 82% were eligible, but the amount who went home with the discharge with the quadruple therapy, that's ARNI, beta blockers, MRA, and SGLT2, were about 15%, whereas 40% went back on triple therapy, and these were all initiated in hospital. Now, when we practice therapy, we know that a patient has come with heart failure, reduced ejection fraction. It sort of reflects for us to not start everything together. We'll start 1, 2, maybe 3 drugs, and then we'll say, okay, on follow-up we'll start. But this is the inhibitions that we have is challenged by this trial. And the outcomes were startling. It showed that, if you'll see this slide itself, these are absolute risks. Usually when trials are presented, the relative risk percentages are shown to us. But this is the absolute risk difference between these 3 arms. Now, the one on the top is optimal medical therapy. The one, is no GDMT. The middle arm is the one where they were on 2 drugs, ACE inhibitors, ARBs, and beta blockers. And the lowest one is people patients who went back on quadruple therapy, including ARNI. And you see the relative risk between these two was 14 and 10%, which is a 4% risk reduction. Whereas between no guideline directed therapy, that's the topmost arm, and getting quadruple therapy, there was a 28% absolute risk reduction. Now, what this tells us is that although a lot of patients are eligible for quadruple therapy, yet less than 1 in 6 are actually prescribed it. And if the clinical trial benefits can be fully realized, the in-hospital titration or initiation of quadruple therapy would yield to a large absolute reduction in mortality. I think this is the most impactful trial, in my opinion, in ACC 2024, because it tells us that a newly diagnosed heart failure with reduced ejection fraction patient should not go home without all these 4 drugs, not 3, not 2, but all 4 drugs, as long as they are eligible. And remember, most patients are actually eligible. Now, so having taken that study, let's go forward to the next study, that is the Paraglide HF study. This trial was released in 2023, and it basically was in patients of heart failure with mildly reduced or preserved ejection fraction, that is EF between 40 and 60%. And this trial showed that when sacubitril valsartan was initiated as compared to other therapy, it led to a reduction in the NT-proBNP levels, better overall hierarchical composite outcomes, which included time to cardiovascular death, number and timings of heart failure hospitalizations, and urgent heart failure visits to the clinics. And it led to reduced worsening of the renal functions. Now, this was also noted, larger reductions were seen when the ejection fraction was lower than 60%, so not with the totally normal ejection fractions. Now, there were 2 subgroup analyses of this which were released, and they answered 2 very specific questions. Now we have a group of patients who are with heart failure with a mildly reduced or preserved ejection fraction. Amongst those patients, question number 1, when should we initiate sacubitril valsartan versus only valsartan? Should it be in hospital or out of hospital? And the outcomes were numerically in favor of starting this at any time, but it showed that it was better to start sacubitril valsartan to reduce the NT-proBNP levels, irrespective to whether you started in or out of hospital. It just showed a benefit over the valsartan subgroup. Now, what this measured is something called a win ratio, where it showed that these patients, rather than measuring, so what happens in these trials is if a patient had a death or a hospitalization, that was an endpoint to their trial. They were not followed up further to see if the patient had worsening or not. So for example, if a patient had a heart failure hospitalization, went home and then died after 2 days, he was marked as a heart failure hospitalization, but not as a CV death, because that was the endpoint of his trial. So this win ratios measured more outcomes, not just deaths, but also deaths, hospitalization, urgent visits, and the change in BNP. And it did show that sacubitril valsartan provided benefits in or out of hospital, but as long as in the subset of heart failure with mildly reduced or preserved ejection fraction. So this was very clear message that it helps to start the combination as compared to valsartan and as early as possible. The second question is, what if it is a new heart failure patient versus a chronic heart failure patient who has worsened? And this was the second subgroup in the same category. And it also showed similar results that de novo and worsening chronic heart failure patients, they see larger reductions in NT-proBNP when the combination is started as compared to valsartan alone. So irrespective of in or out of hospital and irrespective of first diagnosis, that is de novo or chronic heart failure, the group of ARNI is more favorable in terms of NT-proBNP reduction in this subset. Now, this is important because we all know that the heart failure preserved ejection fraction group does not have any great outcomes in terms of a particular group of, it doesn't have these 4 pillars like the reduced heart failure patients do have. So moving forward, in the DAPA, we all know DAPA HF trial, which was one of the landmark studies which changed or added a pillar to the heart failure reduced ejection fraction, 2019 NEJM, absolute risk reduction of 5% in mortality. So this was a very important trial which showed that dapagliflozin was beneficial in patients who had heart failure with reduced ejection fraction. And this was a subgroup analysis of the days of full health loss, meaning it quantifies the amount of advantage that dapagliflozin produces in terms of functionality, not just mortality. And this is what I spoke about earlier, that we don't need to just measure mortality or heart failure. We need to see functionality, quality of life, and other parameters as well. And as you all can see, that the increasing benefit of dapagliflozin kept increasing as time goes by, 120 days, 240 days, and 360 days. So benefit we know, but not only benefit, but quality of life really benefits when we've started this drug in terms of the days of full health lost. So therefore, dapagliflozin reduced the days of full health lost by death, hospitalization, and impaired well-being. So this, and as well, this benefits continues over time. So it's good to start early and continue in the heart failure with reduced ejection fraction. Very clear-cut message, very nice and simple trial. It just gives us how robust this new drug is in terms of heart failure and reduced ejection fraction. What about the same drug in heart failure with mildly reduced and with preserved ejection fraction? So in this group of patients who have de novo heart failure, where it was mildly reduced ejection fraction, we know that here the strategies are not as clear-cut, but in this subset of patients, again, 1,374 patients were included, where they were included in the group where sacubitril valsartan versus an ACE inhibitor ARV were studied, and it showed that the outcomes, patients with de novo presentations of heart failure, they did have a lower risk of all-cause hospitalization compared to ACE inhibitors and ARVs. So remember, like I've said earlier, mortality is not everything. If we can keep our heart failure patients out of hospital, that is also a very big win. So it shows that between these groups of drugs, the sacubitril valsartan is showing to have benefits as well. Now we're moving out of the ARNI group of drugs into a group of drugs which I think is really exciting in terms of patients who struggle with obesity. Semaglutide, which has been a really revolution in the terms of the obesity subset of patients. Remember, there was a wonderful trial which came out in 2023 December in NEGM called the SELECT trial, where semaglutide was used in patients who were diabetic, who were non-diabetic, just for weight loss. And it showed that when 2.4 milligrams of subcutaneous semaglutide was used, it had an excellent cardiovascular benefit in terms of death from cardiovascular causes, non-fatal MI, and strokes, as well as multitude of secondary endpoints. So remember, this is not oral semaglutide which is available in India, but it is the injectable semaglutide which is given once a week subcutaneously. And when this led to weight loss, we don't know that the heart failure outcomes were showing a benefit. But did this same drug does it also have benefits in the heart failure subset? And this trial called the STEP HFpEF trial showed that amongst obese patients with HFpEF, once a weekly semaglutide was superior to placebo in weight loss, and similarly in diabetic patients, it showed a similar outcome. And this is what the outcome is, that not only is there a dramatic drop in the weight, the loss of weight was as much as 8 kilos more in the group which was on semaglutide, and there was a change in the quality of life index. So the improvement in quality of life was also dramatically better. Now, remember that while we have HFpEF where we try and target risk factors, the control of blood sugars, blood pressure, addictions, weight is an important aspect of recovery. So if we have a drug now which is showing cardiovascular safety, cardiovascular benefits in patients who are obese and who have heart failure with preserved ejection fraction, this is really a revolutionary drug. I think this is going to go way, way forward in our future management of heart failure with preserved ejection fraction. Now we are moving forward to the inclisiran group of drugs, the Victrion Initiate study. Now, as you all know that we are focusing on lower and lower LDL goals. The Lipid Association of India has brought down the levels of the LDL targets down to as low as 45 and 40 in the patients who have atherosclerotic cardiovascular disease. And PCSK9 inhibitors, inclisiran particularly, as well as the Ripatha, have shown that there have been benefits in reducing LDL while also keeping the statin doses as low as possible. Now, this trial was designed in patients with atherosclerotic cardiovascular disease who did not achieve the lipid goal in spite of the statin therapy. And a lot of centers enrolled patients and they were followed up for 330 days to look for whether the lipid goal was achieved and also in relation to how many patients were able to tolerate the statins. Now look at the endpoints here, the percentage change in LDL was 7% in the statin group, whereas it was a remarkable 60% reduction in the treatment arm, which was on the inclisiran arm. And look at the time this separated. As soon as you started using this, by 90 days, you start seeing this benefit. And immediately, you see this benefit persists as long as the drug is continued. Now, how much, when you started inclisiran, how many patients maintain less than 70 of LDL? 81%, and less than 55, 71%, compared to 22 and only 9%, which is our target actually for these patients with atherosclerotic heart disease. So if we are talking about reducing future events and LDL targets being one of the main reasons in which your atherosclerotic events reduce, then this drug can be a game changer in terms of having recurrent coronary events. And of course, the safety profile was quite favorable. So LDL lowering first with inclisiran first strategy led to a sustained LDL cholesterol reduction at 330 days as well. And the safety outcomes were quite encouraging in the real world setting. This just highlights the importance of starting this drug early and the urgent need to improve this as part of the regular care in our atherosclerotic heart disease patients. Now, last couple of trials which I will quickly go through. One is a very interesting negative trial, which is the use of empagliflozin in acute myocardial infarctions. So while these drugs have been given such lovely outcomes in our heart failure subset, in an MI patient who's at risk of heart failure, not necessarily has heart failure, is it worthwhile starting this drug for everyone? These are very small questions, but they are important when we are guiding therapy. You have an MI patient, they're at risk for heart failure, but they're not in heart failure. Should we start them on empagliflozin? And the answer is no. It did not give a statistically significant decrease in the composite outcome of death and hospitalization. So very nice subtle message here. If you have heart failure, please start this drug. Start this drug early. But if you have had an MI without heart failure, then this drug may not prove beneficial as we have thought so far. The last trial, which I think is really a groundbreaking trial also, I've left these two trials for discussion right in the beginning and the end. This is called the PREVENT trial. According to me, this trial is going to open a Pandora's box of questions and concerns. Now, this trial was designed for prevention, in the sense of preventive angioplasty, when we have a coronary lesion which is not flow limiting. So please see this trial design. And coronary stenosis 50%, but not significant enough for stenting, with a negative FFR. Please note the FFR showed that it was not significant, but on imaging, the plaques which were in this group were found to be significant, either with a small MLA, large plaque burden, or a thin cap fibroatheroma on IVIS, or a lipid-rich plaque. So these are what we call vulnerable plaques. They should have at least 2 out of these 3 criteria. And these groups were divided into doing an angioplasty in spite of a negative FFR and OMT alone. Now, as we know, the deferred trial gave a clear message to us. The deferred trial, in which negative FFR patients were left alone, it told us that you don't need to stent patients who've got a negative FFR, and it told us it's safe to leave them alone. Very, very few patients had events. Now, in this group, this is completely challenging that deferred trial. if these patients had a vulnerable plaque, in spite of a negative FFR, they went to undergo PCI with either an absorbed biovascular scaffold or a cobalt chromium everolimus eluting stent. And in this subset, surprisingly, it showed that the outcomes, the primary outcome of death MI was and target vessel failure at 2 years was better in the PCI group as compared to OMT group alone. Not only that, this trial kept on going at 7 years. It still showed that outcome benefit persisted. So not only these causes, but the outcomes of any death from any cause, any MI, this also showed an important, significant improvement if the preventive PCI was done. Now, what does this tell us? It tells us that when a patient has an angioplasty in a vulnerable plaque, as long as they have been shown as a vulnerable plaque on imaging, irrespective of the FFR, it is worthwhile to put a stent for these patients. Now, why this is a little bit of a concern is that this trial was done not, although this gives a message that yes, you have a vulnerable plaque, put a stent, but please remember this trial had some limitations. It was not done in all acute coronary patients. Remember the gold standard for a vulnerable plaque is not IVIS, but it is OCT, and not all patients here used OCT. And so this trial did have a lot of shortcomings, because what this trial is going to do is going to give us a very open window to put in stents even in FFR negative patients. So we should leave this trial to discussion amongst our panelists. But with that, I'd like to thank you all for a very patient listening, and we'll take our discussion of these wonderful trials released in ACC 2024 this year.
So thank you very much for a lovely presentation, Dr. Mehta. Am I audible, please?
Yes.
Yes, sir.
So thank you very much for lovely, compiling all the data that you have presented in a very simple way. And I'm sure there are a lot of discussion that we should have with our esteemed faculty today. So let me have I hope Dr. Our faculty are there available physically here. Dr. Viveka Kumar, Dr. Ghosh, and Dr. Andule, all three of you are there.
Yes.
Yeah. Right. So the question, I mean, we have about half an hour time that to discuss about it, but the very interesting point that we have actually come across in these slides. Number one, if you let's come to a practical question, like when you are trying to initiate the quadruple therapy in our patients who are actually got admitted to hospital with either a de novo heart failure or maybe a worsening of the previously known heart failure patient with worsening of symptoms. How practical it is, and how much are we into this kind of quadruple therapy that is being initiated in a rapid way? What is been presented by what we call strong HF trial. So how practical it is, and how much are we really following this kind of a regimen that has been shown to really benefit these patients. So I would invite Dr. Viveka Kumar to comment about it, and followed by Dr. Ghosh. Dr. Viveka Kumar, are you there?
Yeah, so I think if you see, it is quite practical, and we have been, going into this practice, and because it's something where you need to start, 4 pillars as soon as possible, and there are many patients where you can really, if you go with a small dose and build it up over 4 to 6 weeks, that is feasible, and that is the patients are also benefiting, and we have seen the data that it is beneficial. So that is how we should do. So I think it is like how the patients are. Suppose somebody has got chronic kidney disease, or then we try to hold RNA and start with the SGLT2 inhibitor, and likewise, if the person's kidney function is okay and the blood pressure is on the higher side, then we start with RNA and gradually build up the dose. So I think this is beneficial and practical in, I would say, more than 70-75% of the patients. But other group, we have to really stabilize them and then gradually build up the dose.
Okay. So you very well said about it that it is possible to do this, but we are not somehow doing it. It is time for us to actually pull up our socks and trying to put our patients as soon as possible all these four drugs on board. At least the to some kind of a dosage that we can probably incorporate in these people. Dr. Ghosh, I would like to also ask you about this quadruple therapy being initiated in the hospital. You see, from the strong edge of trial, we have known, although the trial shows uh, compared to a usual regimen, a rapid initiation actually reduced the risk reduction to almost like 33% risk reduction. But at the same time, we also had a adverse events of 41% in the rapid initiation group compared to 29% in the usual group. And what is your comment about it? And what do you think that we could probably do to our patients in order to reduce this kind of adverse event, what we have seen in strong HF trial?
See, basically, four drugs are needed. Nobody is debating that. The reason why four drugs are not being given because we take time to change our mindset. The mindset has come because if you look at the older trials, earlier they were saying discharge the patient on an ACC or ARB, and at follow-up you introduce RNI, and then gradually build up the dose. So that is one major reason. The other reason is that if you look at all the four drugs, one drug was given and then that was gone, the dose was gradually increased, and then top of that maximum dose, the second drug was introduced. And then the third drug was introduced, and finally the fourth drug was introduced. So many people feel that we should go that way, step approach, that one by one drug we should be giving. But then this is no longer tenable today. We need to change our mindset, and we need to give four drugs. Why this is important is because now we know that it is more important to give all the four drugs than to give the maximum dose of any particular drug. So if you give us all the four drugs in the minimal doses possible, then probably you will be able to give all the four drugs at the time of discharge, or if not four, at least three you will be able to give, and fourth drug you can give at follow-up. But in majority of the patients, you'll be able to give four drugs if you start with very low doses of all the four drugs. Now, this is also important because these drugs, they have interactions also. One drug may increase the tolerability of the second drug. Like if you're giving an SGLT2 inhibitor, that will reduce the potassium, whereas an MRA will increase the potassium. So you may not be able to give the MRA, but if you give it after an SGLT2 inhibitor, the potassium will be low and the tolerability of MRAs will be high. So because of these reasons, you should start the drugs, all the four drugs or the three drugs at the time of discharge, and then at follow-up, you gradually increase the dose as per tolerability. Now, if you are giving four drugs at the very beginning, many of these patients have low blood pressure. Many of these patients have low GFR. And naturally, if you are giving these patients all the four drugs together, there is a possibility that the adverse events will be higher. And the adverse events, main adverse event would be a low BP or a worsening renal function or a rising potassium. And that you have to take care. And that is the art of practice of medicine. There is no science involved, that how you are giving all the four drugs, best way you can give it so that your complications are minimum. But definitely the complications will be higher. And we need to accept this higher complication rate because we get a huge benefit as far as mortality is concerned. This will help us. With that, there is also important that there are many unnecessary drugs the patient is receiving, or there are many unnecessary things that the patient is eating. We need to look at the prescription. We need to do a good dietary counseling so that the patients do not get problems like worsening renal function or hyperkalemia, and this can be prevented. But there will be complications, and the complication will be higher. The way we practice it is to bring it down to the minimum possible.
So the point is well taken, but the thing is, one of the reasons why strong HF had such a kind of adverse events in the rapid initiation was because of they've had a protocol where they have to give the doubling of the dose or highest amount dose within 2 weeks. So first week they at zero time, they have at the time of admission discharge, they are giving all the four drugs to half the prescribed dose, and then next week they were actually looking at any kind of adverse event that was, and the next week they're actually doubling it up. So
Yeah.
this a greater what we call risk of having adverse events of hypotension and discontinuation of the patients, and also increase in the creatinine. Perhaps, under sitting, I think we probably can modify this regimen and saying that we have to give all the 4 drugs, but we need not have to double it at the second week, and we can individualize the patients, depending on how much they're tolerating. And then looking at what we call the renal function and also potassium and also other concomitant, morbidities the patient has. So each one has what different kind of dosing of each of these 4 pillars, so that we can get best out of all the 4 pillars in a patient who is getting discharged. I think we'll move on to the next question, I think. Very interesting to know about the Paragon trial. And then we know the Paragon trial, we have seen in Paragon trial that by some kind of a dichotomous changes in patients who are involved in Paragon trial, where they have found that women had definitely a better outcome than the men, number one. Number two, they also noted that the patients who are admitted in the hospital with the recent worsening of heart failure with preserved ejection fraction, less than 30 days and less than 6 months, and the patients more than 6 months, and the patient never had a heart failure hospitalization. What they found very interesting data in this, that when they analyzed that the patients who are recently hospitalized less than 30 days had the best protocol outcome. In fact, they probably were statistically decrease in the primary endpoint. So since it is not what we call a primary endpoint, a second endpoint, they were it's only observed that it was a kind of confounding fact that they have found. They wanted a different trial where they could include patients with heart failure with preserved ejection fraction who had recent worsening or recent hospitalization because they didn't know heart failure. And it is interesting to know that 2/3 of these patients were actually pre-diabetic, and 1/3 were actually non-diabetic. There were no pre-diabetes. And then it's also interesting to know that about a quarter of them had ejection fraction more than 60, a quarter of them had less than 50% ejection fraction, and remaining 50% were between 50 and 60. There's interesting analysis about this also. They're saying that the patients who had this ejection fraction between 40 and 45 and 50, and then 50 to 60, they had a better what we call risk reduction than those patients who are analyzed beyond 60 ejection fraction. So this is another interesting feature that I actually noted in the Paragon trial. So it shows that perhaps there are patients who are having ejection fraction with preserved fraction with hospitalization recently probably have a better outcome with the RNA molecule when we consider patients between ejection fraction between 45 to 60, and then probably we have a less benefit beyond 60 ejection fraction. Now the question is, are we convinced about the data, and do we have to consider this RNA molecule in patients with the preserved ejection fraction? Can we use it as one of the molecules for benefit of patients with the heart failure with preserved fraction? Can I involve Dr. Vivek Kumar to comment on this?
Yeah, so I think you're right that there is some.
I think there seems to be some problem with the contact. Maybe Dr. Ghosh, can you take up this question and then comment on this?
Yes, so basically when we use a drug, we look at two main things. What is the magnitude of the benefit? And what is the adverse effect profile? What is the safety and tolerability? So we look at this and prescribe a drug. Now, when we are using RNA in patients with ejection fraction less than 40%, we know that there is a huge benefit. And statistically, it is very, very significant, p-values of 0.00001. Now, if the ejection fraction increases from 40 to 41 or 42, there is going to be a benefit. Suddenly it cannot become negative trial. So there is going to be a benefit. But what we realize from these results is that as the ejection fraction increases, the magnitude of benefit decreases. And once the ejection fraction is above normal, so more than 57% or 60%, whatever you say. So once the ejection fraction is more than 57%, there is hardly any benefit. So between 40% and 57%, there is a benefit, but as the ejection fraction is increasing, the magnitude of benefit is decreasing. So in patient with an heart failure with preserved ejection fraction, with an ejection fraction of more than 60%, I'm not going to use this drug because there is hardly any benefit, whereas the side effects will still be there. And between 40 to 57%, definitely I will be using this drug. But again, I will decide, the decision will depend upon how important it is to use this drug. What is the blood pressure? What is the frequency of heart failure? What is the NT-proBNP levels? So on the basis of this, I will decide where to use it and where not to use it. But definitely as the ejection fraction decreases and goes towards 40, there is a higher and higher need of using this drug in every patient.
So, in other words, 60% ejection fraction is a cutoff. About 60, I think probably they may not have that much of benefit. But between 50 and 60 also, the greatest benefit is those people who had a recent hospitalization with ejection fraction. If they don't have recent history of hospitalization recently, perhaps the effect is not that great. In fact, it would touch a statistical significance if you include this kind of patients when we are comparing to valsartan. And perhaps we probably can use this molecule as a one of the pillars for treatment of heart failure with ejection fraction. If they had a ejection fraction between 50 and 60, but then if they had particularly a recent hospitalization. So that's probably.
Can I just say something, sir?
Go ahead.
So just one thing you touched upon is about whether the statistics and the trial data is what we should interpret. And I think, a lot of the times, if you see the outcomes you're talking about, when we say benefit, here we are talking about a benefit in NT-proBNP reduction. And as we all know, heart failure is not defined by just the NT-proBNP. It's a clinical syndrome. So if we are talking about these soft benefits, I agree with you all completely that any low ejection fraction, this drug helps the fibrosis, remodeling of the heart. But when you have a normal ejection fraction, we have to understand whether cheaper drugs, other drugs like valsartan, which don't need as much monitoring, might be a safer option for our patients. So the statistics which show the benefit are sometimes, are I won't say manipulated, but they are designed in a way to show us these benefits when they will not necessarily be as clinically significant.
No, I think
can I also put in there? I mean,
I just want to comment about this. We're not speaking about the surrogate markers of heart failure when you're saying benefit. We're also speaking about heart failure hospitalization as well. So in terms of heart failure hospitalization that we are speaking, not just necessary to speak about only NT-proBNP reduction. In fact, we are speaking especially in this particular trial, Paragon trial as well as Paraglide trial, the hospital heart failure. And of course, the mortality was actually not significant at all in these trials. But certainly, if you look at the hospitalization heart failure in Paraglide trial, a subset of population it touched significance. Although this was only exploratory, but not necessarily the primary endpoint. But if you see the magnitude of reduction of NT-proBNP, of course, that showed a definite evidence of benefit. But if you look at hospitalization heart failure, it was also significant in this subset of population. I'm sorry,
No, I just wanted to put the same point. I think it is only for subset which has been hospitalized in hospital heart failure with a preserved ejection fraction. I think it's not for a routine. It's merely overkill for a treatment of a patient if you're talking about not preserved ejection fractions with ARNIS. So I think this subset, what we are talking about in this trial, is only in hospital heart failure with preserved ejection fractions. So that's how it is. So I just wanted to also put up from a surgeon's perspective. So as I said that right from all two questions, I'll just try to cover in. Being a surgeon, most of the patients who come to me are mildly reduced ejection fraction or reduced ejection fractions, and maybe because they have been sent for surgeries. So that was where I was one of the first proponent and ardent use of ARNIs in my practice from years now, from the time it has come into market. And I still feel there is a lot of resistance, no doubt about it, to initiate this molecule. But then I have also gone into this cortical therapy with an idea that I start the therapy with adjusted dose, because the Indian subset never tolerates what has been prescribed for the Western P patients. Even if I have to go down to 25 milligram of any ARNIs and to divide it two doses, don't mind to do it to just make it. But I just initiate it and then start titrating it. I think that's the best way to introduce safely, and quickly you can move on to the required dose if the patient is tolerating. And I have seen most of the time, and most of my patients are now going with this, and they are doing excellent. We need to have a proper database in surgical patient also post-operatively. If you initiate this patient, because I feel surgery is not all, it's not a full-time treatment for this patient. We have to initiate them this medical treatment. We have to initiate the quadruple therapy, and these patients do far better than patients who are just going on subclinical treatment.
Great.
Thank you.
Comment from your side. So just before we go to the next point, next study that we presented, you would also have to think about other modalities of treatment of heart failure with ejection fraction. Semaglutide. Of late, we have a lot of data that's coming out with semaglutide. So although we have a semaglutide molecule which is essentially marketed as a drug which is treated for diabetes, but we have a host of evidence to show that just like SGLT inhibitors is going to be a cardiovascular molecule, and we have the data to show when with the ejection fraction that we do have some kind of benefits of semaglutide. So can I have some comments from Dr. Ghosh, what you feel about the semaglutide molecule to be used as one of the molecules for the treatment of heart failure with ejection fraction?
So basically, we know that obesity is an important risk factor for heart failure with preserved ejection fraction. And semaglutide 2.4 milligram subcutaneous injection, it's a very good drug. It's already approved by US FDA for the treatment of obesity without diabetes. And with the obesity coming down now, we have proved that definitely heart failure with preserved ejection fraction is also decreasing. But I don't think much about this drug. Why? I'll tell you, because this is not approved in India, first thing. Second thing, this is not available in India. And third is cost is exorbitant. So I don't think I'm going to use it. And when I'm going to use it, I also don't know. But because of these things, I'm not thinking much about this drug. But yes, the studies have shown that it reduces obesity. And by reducing obesity, it reduces heart failure with preserved ejection fraction in patients with obesity and heart failure.
But Dr. Ghosh, as a part of our discussion, I'm just saying there is a fair amount of our patient profile who now we are finding obesity into this subset. I mean, the cardiovascular coming for interventions. So, and most of them are affording patients. If you talk about going for angioplasties, which is fairly expensive treatment. So I think this subset is fairly going to benefit from introduction of semaglutide to them. Because just sheer reduction in their body weight is just going to make a remarkable, difference in their cardiovascular status.
I totally agree with you. Definitely, it is a wonderful drug. But the question is when it will be available and when I'll be able to use it. That is the question. I do not agree that this is a very good drug. It's a very good drug.
It's a good drug, number one. Number two is it is likely to it is being delayed in introduction in India for two reasons, because we don't have one. Number two is they are not able to supply that molecule in India because
that is the problem. They are unable to make so much of semaglutide injections.
Not able to make
and it is available. It is coming from Dhaka, semaglutide injections in the Kolkata market, and actually that is not made by Novo Nordisk. I don't know, and that is also costing 15,000 for one injection. I don't know how good it is.
No,
whether you should use it or not.
The reason for that we're not being available is unable to match the demand all over the world. In fact, it's being sold in black also many of the metros. But the thing is, we have three studies show the step heart failure with preserved fraction in diabetes and non-diabetic also. Dr. Mehta, can you tell us why it was actually studied in diabetes as well, when we know already non-diabetic population had a benefit of reduction in the hospital heart failure in patients with preserved ejection fraction?
So I think that, sir, it has to be studied in every subset. Just because the injectable drugs show a benefit, it's not necessarily that the oral tablets will have the same benefit. And similarly, now semaglutide injectable, we are discussing that it has a weight loss between 10 to 20% of your body weight. Weight loss will lead to improvement in your lipids, sugars, blood pressure, sleep apnea. There are now studies coming on the next molecule, which is tirzepatide, and on another molecule called cangrelitide. And these studies are also showing reduction of weight, which causes improvement in cardiovascular outcomes. In fact, now there is a study which we are conducting in Mumbai on a combination of cangrelitide and semaglutide, both in obese patients with atherosclerotic heart disease. And we're going to see those outcomes. So these are exciting new molecules, but they do need to be studied. And at the moment, I think they're being abused for weight loss. They're a shortcut for weight loss. We can stick to our discussion on heart failure patients who are obese, because they definitely have a benefit in reduction of weight. I think even things like improvement of exercise capacity, it gives them a positive outlook to life. The diet improves. So tremendous benefits on all aspects of wellness.
Yeah, that reason perhaps I think that this drug was also studied in diabetic population, despite the fact we have very good evidence to show that significant reduction in well-being and also improvement in the 6-minute walk test by them, and also NT-proBNP, is that diabetic population are a difficult population to lose weight. They don't lose weight that easily. Number one. Number two, they have much more heart failure than non-diabetic population with equal amount of weight. So that's the reason I think they wanted to prove that it is in diabetic population as well with preserved fraction heart failure. And certainly, as although the drug is expensive, but nevertheless, one single hospital in any of the metro hospitals or any of the hospitals, corporate hospital, is going to have constant form. And then that probably will give them enough money for spending in the hospital, one hospitalization for 2 or 3 days for entire year, money to purchase this drug. So I think it is definitely when we have no other good molecules for treatment of this element of heart failure with preserved fraction, this coming as what you call some ray of hope for these people. In fact, we also know that select trial, as you were presented, see, the one important thing that in the trial is that about 75% patients were in this trial were pre-diabetic, and it prevented them going into frank diabetes, number one. And those people, 25% of the population who are non-pre-diabetic, prevented them going into a pre-diabetic status. So number one is preventing diabetes. It reduces, HSCRP to a significant level. And what more important is, there's a 30% reduction in the renal endpoints also in this. In fact, they prevented onset of renal failure and also progression of renal failure in these patients. So it's a great molecule as far as the obesity is concerned. I think the only thing is the cost is going to be prohibitive for us. And then with the interest of time, I think we'll go to the last presentation of yours, which is very interesting to know, very new concept. It's not a really new concept, but the PREVENT trial, where they have shown that non-hemodynamically important lesions, when they are actually high-risk nature by IVUS or maybe by OCT, and doing a kind of intervention then. So this is another interesting article they've said. But way back, people in Switzerland, when stents, when we didn't have even regular stents in 1994, 95, when regular stents were just coming into the market, they actually had a concept of patients who got vulnerable plaque. If you stent them, what you get is only a restenosis, if at all, but it will prevent them having acute rupture. So you prevent MI in this kind of high-risk lesions. But at the same time, even if you put a stent and if you have restenosis, you will only have angina, but not acute cardiac death because of acute MI. That was a concept that was evolving from 1992, 93 at that time. And now we have a dedicated trial to answer this question, whether treating a non-hemolytic important lesions in coronary tree with a intervention is it going to be a important thing if they are a high risk nature. So your comments on this, Dr. Ghosh, what do you feel about? Do you think that can this come into what you call in the guidelines? Dr. Ghosh, please unmute your mic.
Sir, you are mute.
So when we were giving statins had come in new at that time, mid-90s. So when we were giving statins, there was a 25% reduction in MI, and there was a reduction in mortality, stroke. So we were very happy. And we thought that the plaques are going away. But then we saw, what we realized is that there's no reduction in the degree of stenosis. And then we realized that it is the change in character of the plaque, which is actually reducing the MI and improving the survival. So the degree of stenosis was never important after the statins came in. Now we did not have any marker, and the surrogate marker was FFR. So surrogate marker was FFR, and so FFR was taken, and it showed that statistically there was a benefit if we are treating only significant blockages we were treating. And the patients which had a large degree of stenosis invariably had a large plaque, and definitely there is going to be benefit. But if you're treating plaques which are not all that large and not causing a severe degree of stenosis, many of these plaques may be actually not leading to an MI, but some of them will lead to an MI if they are very vulnerable, like they have a large amount of fat, lipid core is there. If the fibrous core is the fibrous cap is very, very thin. So these are the plaques which can rupture, and we know from the pathology studies which were done at least 30-40 years back that a large majority of the MIs are caused by rupture of plaques which are actually very small and which do not cause small degree of stenosis. Now, at least this study has shown that there is a way we can identify these plaques which are likely to rupture, and if we treat them, we are going to get a benefit. I'm not saying that we should immediately come into the guidelines, but this is a very good beginning, and I believe that similar studies will come more and more, and that will confirm our faith in going for looking at plaque nature rather than the plaque size or degree of stenosis. And in future, we will go by the plaque nature to decide about angioplasty and not just by the degree of stenosis.
Great. The problem in this is, before I can actually comment on this, can I ask Dr. Mehta to comment about it?
So, I actually was quite surprised with this study and the outcomes, because they were quite surprising outcomes. So I went through the limitations of this study, and what I realized is that around more than 50, nearly 60% of patients were not patients who had acute coronary syndrome. They were patients who had chronic coronary syndrome, multiple lesions. They had stents in either group, and on evaluation of a 50% plaque, they tried to see if this is vulnerable or not. And so then extrapolating those reports to a patient who's actually got an NSTEMI might be different. And secondly, they used a lot of IVIS here to determine whether these were sort of vulnerable plaques, whereas OCT we know is the gold standard for this. Even on IVIS, to measure the thin cap fibrous atheroma may not be as adequate as it is on OCT. There are a lot of limitations to this trial. I certainly agree that looking at plaque morphology is important, but so far we also have negative trials which say that we don't know what to do with these vulnerable plaques. We have studies which say that when you give a very high dose of statins, get your LDL down, the composition of the lipid core and the composition of the thin cap changes. So we need to know whether this is a subgroup where we are putting a stent, which is like a permanent you're adding another disease to the coronary artery. Stents are sometimes not as benign as they are projected to be. So I will still take this as a sort of with a pinch of salt, this study, although the results, I mean, the center that's been done in Korea is a very good center, Dr. Sujong Park Center. They are very scientifically sound. But I will wait for some more trials before putting stents in FFR negative patients. So, for example, sir, what if we have, and maybe I can direct this to Dr. Hamdule. What if we have 3 vessel disease, all 50% lesions, all FFR negatives, but all vulnerable plaques? Will Dr. Hamdule do a CABG for that patient? Because the grafts are not going to hold in that patient.
It's not. So yeah, that's what exactly. I think introduction of OCT is an important part in most of the cath lab, because we need to do this, because this type of patients, I mean, I see it's not only about one graft or two triple vessel. It can be two significant, and the third one is 50% block. Then what should I do? Should I graft that, or should I leave it? So in those scenarios, I think whenever we do an angio, if we can extend our investigations and be sure that okay, this need to be addressed, this is bad, then is where we can need to intervene or revascularize those segments, whether it is hybrid process or it is just putting up a graft. So eventually this is what is going to be our practice. I mean, hybrid approach to most of the things, get OCTs, define each and every lesion, and then give the best outcome to the patients. I mean, what you say that yes, the study is more for chronic patients when they have put up the results accordingly. But what happens exactly in acute cases or end-stages, whether for those patients, I think we need to do an OCT. I'm sure you'll agree to this.
But between, if you have a patient who has got vulnerable plaque, and then if it is not hematologically important, giving a graft is going to be a suicidal thing, because graft is going to compete with the natural flow and it's going to close. But then, Dr. Mehta, what do you feel about it? You say that putting a metallic, permanent metallic, structure there is not a good thing. But what about putting a vascular scaffold in them, bioabsorbable? What do you feel about this?
Yeah, I think that's a very important point, Dr. Rao, because if we are talking about putting stents so what are we trying to do when we are putting a stent? We are trying to change the plaque morphology, trying to get a new intima out there so that it sort of reduces the risks of plaque rupture and sections. And if that can be done with a scaffold which will then disappear in 2 years, I think that would be a definitely better option than putting a metallic stent, especially for the younger age group of people. So I think that's what I said when I was presenting this topic. It's a Pandora's box. It can lead to discussions at various aspects, not only from to stent or not to stent, to graft, not to graft, which kind of stent, even the authenticity of the trial, the subset of patients, a lot of questions this trials has raised, but it has opened the doors to seeing plaque morphology in much more detail and not just relying on FFR blindly.
Yeah, one important thing is that if you look at this analysis of this trial, at the end of 2 years and at the 7 years, they wanted to see what is the outcome. But then what they showed is an interesting fact that everolimus stent did better than vascular scaffold. In fact, they even more in the average.
So that is because I think the biovascular scaffold also went out of vogue.
It's existence now, but not in India though, because of some kind of constraints from the regulatory authorities here. The other thing is, most important thing when you understand, the leading article published in New England Journal of Medicine about 20 years back, we said every MI, when you see a region which are ruptured and cause occlusion of a coronary artery, several such plaques are ruptured, but does not propagate themselves into a kind of MI because they do not cause a complete occlusion. So it's a pan-vascularity that you see in a patient with the ACS. Now, the problem now is that not every lesion which is with vulnerability is 50% in luminal narrowing. Many of the MIs do occur when the lesions are less than 50%, in fact, which you see, sometimes you will see the trivial lesion there. So the vulnerability not necessarily confined to only 50%. So when you're looking at this vulnerability, looking at the 50% luminal narrowing, it is not correct, because several such kind of plaques are there which are likely to rupture and cause propagation of MI. So this is where the another question that comes out is how to actually go about with this concept of what you call treating a vulnerable plaque when it's not hemoglobin stable. How many of them will you send, and how far will you go? This is the kind of a dilemma we have. And I think I think we are nearing the end of this session now. I think within
Sir,
this.
just with your kind request, one question I'll take from the audience. Dr. Nihar Mehta presented about inclisiran therapy. So it's a new thing. So I have got a lot of questions. So I request the panelists, Dr. Viveka Kumar, Dr. Rao, Dr. Ghosh, Dr. Hamdullah, to please share your views on this new molecule. Just one last question from the audience, if you can share your views.
We'll start with Dr. Ghosh and Dr. Viveka Kumar.
Yeah, it's a good drug, very good drug to reduce the LDL levels. So basically, once you're given full dose of statins and 10 milligram of ezetimibe, and still your LDLs are not in target, you can give it, and it's simple. Compliance is very good because 2 injections a year. And other than some local site reactions, there is hardly any side effect. Only thing is the price is still a problem. Price has to come down. Otherwise, I think this is a very good drug. And these vulnerable plaques, at this point of time, I will just give inclisiran only and statins and inclisiran only to treat. Maybe if further trials come up which show good result with plaque morphology, then we may change our practice, but not now.
Dr. Ghosh, is a lakh of rupees of an injection. I think I can put 2 stents in it.
Okay. Dr. Viveka Kumar, is he there?
Yeah, so I think I fully agree that the inclisiran is going to be a wonder drug, and we have used in initial experiences also in our. So one thing which we have not really realized, and there's not much data about the familial hypercholesterolemia in our population. We have seen that there is no other drug would work in these group of drug, and patient subset where the LDL cholesterol and the triglyceride and everything is high. So in these situations, to bring them to less than 50% of the baseline or to get the LDL below 50, this is the drug which is going to work. And in current perspective, if you see that we are seeing a very rising trend of young myocardial infarction patients, especially the generation which is working in work from home or multinationals and all. And so recently I had a surge of patients who say that, doc, instead of taking medicine every day, can I just take a shot and be quiet for 6 months? So I think this has got a huge future, and scientifically also, as Dr. Ghosh said, that the data is quite clear that it is the vulnerable thin cap plaque which ruptures and can cause MI, and even 10-20% can do acute myocardial infarction. So there also the stability of the plaque would be much better if we get the cholesterol down, and also what it does is that it decreases the lipoprotein little a also, which is a big risk factor in Indian populations. I would say that as Dr. Hamdullah said rightly, that the cost is a big barrier, but if that comes down with increasing uses, probably this will be another non-intervention techniques to pacify the vulnerable plaques.
Komal, I have a comment on this, Krishnaran. I mean, it's a good molecule. Basically, it's a wonderful science that is backing this. But you see, about this drug, this is less expensive than currently available PCSK9. For example, the two shots in a year, it might cost about 2 lakhs. But if you go on giving every 2 weeks, the PCSK9 inhibitors, then it's going to cost almost double, more than double. In fact, 20,000 every week, 40,000 every month into 12. The cost is almost more than double. So this number one is, it is decreasing the number of injections. Every 15 days getting an injection is boring. And once in 6 months is welcome. Number one, the cost also is encouraging. And the third thing is, most importantly, is that what is important is when you are trying to look at every 15 days one injection, and if you don't take the injection and again LDL goes up, there is an interesting study to show that this fluctuations when LDL goes up like this, because regular treatment, the outcomes are not very good. So if you have a drug which acts for a very 6 months and you decrease this, increase and decrease of this LDL cholesterol because you have been not regularly taking every 2 weeks, the outcomes will be what we call much better if it is consistent decrease without a fluctuations. Most important point that probably this one molecule will suffer is it depends upon the manufacturing of the PCSK9, not on inhibiting the PCSK9. So in this setting of ACS, when you give PCSK9 molecules, you tend to see the results within about 7 days. But in case of inclisiran, it takes in a month. So if if you want to pacify the plague very early and you want to achieve LDL cholesterol very, very hard, you need to actually use a PCSK initially, and then later on, along with the statins, you actually switch to inclisiran because it takes time for it to act. This we must remember that many people actually try to give this in the ACS setting is not going to be useful in ACS setting because by the time it comes into action, it takes time.
Yeah, I think in our Indian population, compliance is the biggest problems, and so I think this will make a big difference. Taking just 2 injections in a year. Also, I don't think we are struggling to get the LDL level down below 50, 55 with statins. So eventually, I think once cost inhibitions go away, this drug is going to be used more frequently in our population.
Thanks, sir. Now I request Dr. M.S. Rao, sir, to please give the concluding remarks for the meeting.
So first of all, let me thank the organizers for getting all of us onto the common platform, and we have a wonderful discussion along with eminent panelists here, and also a wonderful presentation by Dr. Nihar Mehta. And we're also happy to have our surgical colleague to be here with us and telling us about something about the surgical subset of these patients who are having this heart failure and other high-risk population. And we're happy to know that some ray of hope is there for the patients with heart failure with rejection fraction, especially with the advent of use semaglutide, because we have select trial which has come as a positive trial, but also if recently the flow trial also has been published, which is a renal outcome trial, where again the cardiovascular risk was also reduced, although it is primarily a renal study, non-diabetic and diabetic as well. But we find that there is a decrease in the cardiovascular outcomes also in the trial. So multiple amount of data that we have to show that this is not a diabetic molecule, it is a cardiovascular molecule, it is a cardiologist molecule. We have to actually use it in patients with patients with obesity and also patients who have especially the obese. And of course, we also know that empagliflozin, which has been used in heart failure patients with recently admitted with acute MI. The only thing that here the trial suffers from 2 things. Number one, the mortality between, if you look at the mortality or risk that you look at between an STMI and non-STMI. The STMI has got a much more tendency to have bad outcomes compared to STMI, because STMI people get into the hospital, they get revascularized, and then they are getting into the hospital with very outcomes with primary angioplasty or maybe reconvalescence with the drugs which are available. So, but NSTMI recurrent MIs are much more common. They tend to have mortality in hospital mortality much more higher. But in this population, they studied, 75% of the population was NSTMI. Only 1/3 of them are 70% of them are STMI, that is elevation MI, and only 25% were non-STMI. And then when the patients who got any STMI, they are actually having mortality. The mortality is not depends upon the heart failure. That mortality depends on the cardiovascular ruptures and thrombosis, or maybe re-MI because of vascular problems. So then if you look, another problem is that this study actually was going through the COVID period when many of the patients could not be hospitalized. So they are treated as hospitalization of heart failure as outpatient patients. So if you look at what you call, this is not a part of the analysis, but if you look at what you call, the in-depth, data of this, it shows that patients who are actually regarded as outpatient heart failure patients and patients who are admitted with heart failure, if you combine them, then it is significant. The mortality benefit also is there, but this is not part of the trial. So unfortunately, we can't take this molecule. But there is definite evidence at least partly, to show this molecule decreases the rehospitalization with heart failure. And rehospitalization also is an important thing to prevent in patients with ischemic heart disease. And thank you very much, Kamal, for actually getting all of us together. It's wonderful to listen to our esteemed colleagues from their whatever discussion. And it's always important to learn from each other. Thank you so much.
Yeah. So on behalf of JB Pharma, I would like to thank all the esteemed expert panelists here for sharing the wonderful insights on this ACC program. And these are very helpful for all physicians for understanding and implicating these clinical trials in their clinical practice. Thanks a lot, all the panelists. Thank you, sir.
Thank you.
Thank you.
Bye-bye.
Bye-bye.
Thank you, sir.
Bye. Good night. Thanks, Dr. Nihar Mehta, sir. Thanks a lot. Thanks, Dr. Hamdullah, sir. Thank you.
Yeah, thank you so much,
Thanks a lot,
everyone.
sir. It was a wonderful session. Thank you, sir.
Thank you so much, sir. So from here, I'm ending this meeting. Thank you.